Good afternoon. I'm Michael MSeereiter with the New York Alliance for Inclusion and Innovation. Thank you. I'd like to start with a thank you to you for your ongoing support and the support from the governor for our workforce, which is really the backbone of the IDD industry and the sector. We're very pleased to see the increase for the Be Fair to Direct Care campaign and the effort reflected in the governor's budget for a 2% increase this year taking effect on April 1st. I would say that wages, I think, are only part of that equation, however. I think that another piece of that puzzle to address what is a huge workforce challenge for our sector is also a credential. And we would urge resources to be supportive of the piece of legislation sponsored by Senator Carlucci and Assemblymember Gunther related to a DSP pilot. I would like to quickly address something the Commissioner addressed earlier, speaking around DSP wages and the fact that New York State enjoys DSP wages that are typically higher than most other states. I think the question really needs to be asked about what is the cost of living in New York State as it relates to those wages, and furthermore, what is the value of the supports and services that direct support professionals provide? I would argue it is not minimum wage work. So we are indeed pivoting our advocacy efforts, and we're very pleased to be working with the New York Disability Advocates and the larger 3 for 5 campaign for the 3% increase each year for 5 years, as my colleagues here have more eloquently articulated today than I will. I will say 3 quick things about this. Well, number one, the flexible resources we seek would do 3 things. 1, it would stabilize the sector. Number 2, it would provide the opportunity for provider organizations that operate in the sector to be planful about their futures. And lastly, it would actually allow us to continue the workforce investments that began under the Be Fair to Direct Care campaign. Another thing that Commissioner Kastner articulated earlier was that the cost-based methodology that currently is the methodology by which provider organizations are funded in this sector is probably the most favorable of any of the structures. I would say that that's probably true. However, that's not necessarily true when you artificially suppress those rates with a budget neutrality factor or other across-the-board reductions like those that were articulated today. So the rates are indeed less than what it costs to provide services. And just as a kind of a passing, those are rates that are reflected 2 years after the services are delivered. And again, they have not been reflected of any of the cost of living adjustments that this sector needs and has not been privy to over a period of about a decade now. On the Medicaid redesign team, number 2, we're watching this very carefully and cautiously. We would encourage you to do the same. There seems to be no reason that this process can't improve on the previous process of the MRT1 in 3 particular areas. Number 1 being improved representation for the populations that are impacted. Number 2 being improved stakeholder input. And number 3 being an improved opportunity for reviewing the recommendations that are ultimately put forward. Lastly, on managed care. We heard today, and we've heard through the governor's budget proposal, that the SIP-PL plan qualification document is expected shortly. If indeed the IDD sector is to continue to move toward managed care, it needs, I believe, 4 things. Number 1, a continued investment in readiness resources, including the managed care community of practice that Senator Seward was asking about earlier, which is a project of the New York Alliance. I will say 2 things about the managed care community of practice. One is that we are beginning the work to specifically try to address some of the itch points, the concerns related to the CCO implementation, and we are happily taking up some of that work, which will be starting with an inclusive conversation of everyone and all stakeholders involved in the system. Number 2, I would say that very shortly we will be delivering to your offices a white paper that discusses the implications for New York State based on a study of 5 other states that have already implemented managed care for the IDD sector and what can be learned from those experiences. The second on my list of things that are necessary for success in managed care are investments in health information technology to be able to operate in a managed care structure. Number 3 would be an IDD ombudsperson program, specifically geared for the specific needs of this population. It is a very different population than all of the other populations that have moved to managed care. And lastly, I will quote from the transformation panel recommendations from now I believe it was 5 years ago, to, quote, identify funding to meet the administrative costs of managed care distinct from funding required to meet the needs of individuals for services. Under no means can the resources necessary to stand up that system come out of the existing service provider sector or by any means out of those services and supports that individuals and families rely on a day-to-day basis. Thank you.
Well, thank you for your testimony, and thank all of you for your commitment to protecting our most vulnerable populations. I share the concerns that all of you addressed today, and I think many of our colleagues do as well. I just wanted to ask you to elaborate more upon, because we didn't get time to talk about it today, about the credentialing program, how you see that working and how it will help to give a better experience to the people that are being served.
Several years ago, the legislature appropriated funds to study this program, study this idea in its totality. And the recommendations that came out of that report really talk about how the credential needs to be accompanied by what is already in the existing system. When we talk about core competencies, that's kind of the base, right? And then on top of that, you want to start to strive for excellence. And between the two of those things, you start to actually move a system toward identifying those opportunities for improving quality. Quality is a definition that I think, the definition of quality in this sector is something that is not yet fully defined. In fact, I think we're in the process of that right now. If we are to be playing a role in helping to make that helping to define what that is, and certainly improving the lives of individuals with disabilities that these services and supports are designed to do, we need to be striving for that excellence. And in doing so, that the credential starts to push the system, and it starts to create the opportunities for people who want to be a direct support professional to do this and to make it a career, which is really where I think the secret sauce is. It's in the relationship between the individual served and the person providing those services. The longevity of that relationship, the quality of that relationship drive so much of what we see in terms of the outcomes, I think, that are possible in this system.
Thank you. And
Sure.
I wanted to, I just wanted to also thank you for your advocacy for the 3 for 5 campaign. It's so important that we get the funding into the system. And also, I want to thank you for bringing to the attention that it was stated earlier that our DSPs are paid at a level top in the country compared to other states. And I think it's important that we remind everyone that we really can't be looking to other states. If we want to go backwards, maybe we'll do that, but we want to continue to go forward. And New York is consistently seen as a leader in providing services to our most vulnerable populations. And I think we have to isolate ourselves from that and not look to go backwards, but look to go forward and continue to be an example for other states to follow. So I just want to thank you for bringing that point up and really correcting that statement that was said earlier. Thank you. Thank you, Chair.
Senator Jim Seward.
Yes, one question for the panel. I know some of you have talked about this in general terms, but I wanted to get your assessment of the CCOs and the impact on services to those that need the services in the DD community.
I'll take one.
I mean, how's it going, I guess is that.
You know, I think for it being a program that's not quite 2 years old, it's going well considering what we did and how we totally did away with one whole piece of what we had come to rely on, which was Medicare, our Medicaid service coordinators, and moved to something different. So I think in that regard, it's doing well. I think, and we did hear the commissioner talk today, and I was really glad to hear him say they are meeting weekly because we as providers have sent our concerns because there still are concerns. I think the hardest part is for the families. They were very used to a very close relationship with their service coordinators because the CCOs have had to, they have larger geographic territories, and they've had to change how they really have been able to assign people. People have had to get to know new folks, and they've had so much pressure to do the life plans that they probably haven't had as much time to really begin to integrate into people's lives a little bit more. But I think for being a new program, it's really moved along quite remarkably.
I would echo that, actually. I think, when you look at the larger trajectory of implementing a system change to that magnitude, you're now 19 months into the process, roughly. I think it has gone along quite well, all things considered. I think that there's also I think there are some fundamental issues that do need to be addressed with the existing the system that we now have. We're now, again, 19 months into implementation. That's no longer part of the implementation period. But I think that there are expectations that are either unrealistic or don't match up with what the service system is now looking like. I think it is an oversimplification to say that it is simply a shift of the Medicaid service coordination capacity from the previous process to the care coordination structure. It's different. It is a health home model, and the scope and magnitude of the responsibilities of the health home and the care managers who work for them are different than those that were for the Medicaid service coordinators. So setting those expectations and helping everyone understand what the roles and responsibilities are, I think we need to go back and do a little bit of going back to basics. And that's actually where we're going to try to focus some of our managed care efforts, managed care community practice efforts, to try to help understand what is it that we can actually expect out of this process and what are reasonable expectations.
But I can say, as a parent and also as a association rep, that we as parents, we've always worked with OPWDD and the volunteer sector. We've worked very closely with them. So yes, this, as Susan did say, was a tremendous leap for the families, but they are resilient. And I will tell you that the OPWDD providers, they worked with us, and the CCOs, because the CCOs, many of them were the providers. So it was a tremendous transformation, which I think is starting to find its way, because as Michael was saying, now they're going back and saying, okay, what were the mistakes? And we're going to work together. And I think that's what is so wonderful, is the collaboration. And if we could get this 3 to 5, we can continue that collaboration, which parents need to continue to be like myself, to continue to work and have quality of life and still maintain your individual at home longer, because you're getting the good services from these provider agencies. So it's all a collaboration that needs to continue.
Thank you for your assessment.
Yes.
Thank you very much, all three of you. Appreciate it.
Thank you.
Thanks.